Muy buenas tardes a todos. Muchas gracias por venir a este webinar con el webinar de la Asociación del Estudio de la Menopausia. Muchas gracias para eso. Y deseábamos hacer este webinar para hablar de cómo el TBS puede ayudar a mejorar la detección y el tratamiento de las mujeres con osteoporosis durante la menopausia. Entonces, esta noche, ahora mismo estoy aquí con mi colega, la doctora Karen, y también normalmente debíamos tener la doctora Silvia Pérez González, pero lamentablemente que no está disponible esta noche para hacer la reunión. Entonces, ella ha hecho una pequeña video para que ella pueda hacer su introducción del dominio de la osteoporosis a vosotros y después dejaré la presentación de la doctora Karen. Para presentarme un poquito, soy Anthony Simón de la Sociedad Minimaps, me encarga de las ventas del territorio de Francia, también de España y de América Latina. Y la doctora Karen Id es nuestra vicepresidenta de Asuntos Clínicos, Investigación y Innovación. Una pequeña precisión es que la doctora Karen Id lamentablemente no puede hablar español, solamente puede hablar en inglés durante esta presentación, pero si necesita ayuda para la translación, estaré disponible. No dude en avisarme. También, por favor, si tiene algunas preguntas sobre el TBS o el tema de los que vamos a decir, no dudes en escribirlo en la pequeña preguntas-respuestas para que podamos contestar a todas las preguntas al fin del webinar. Entonces, perfecto. Dr. Karen, I just presented ourselves. I don't know if you want to add a little bit of something before I show the video of Dr. Silvia.
No, thank you very much for what I think was an introduction. My Spanish is not very good, but I'm speaking English and I'll speak very carefully and clearly. So hopefully it's easy to follow for everybody. But thank you, and it's a pleasure to be here today to talk to you.
Bueno, perfecto. La cosa es que también creo que se puede activar los subtítulos en en el Zoom. Creo que si necesitan ayuda, tal vez será perfecto para vosotros para intentar de leer un poquito más y entender mejor tal vez la doctora Karen. Bueno. Entonces, como he dicho, la doctora Silvia Pérez no pudo asistir a la reunión esta tarde, pero ha hecho una pequeña presentación que voy a compartir ahora mismo. Es una introducción al dominio de osteoporosis.
Muy buenas tardes a todos y muy bienvenidos a este primer webinar de la Vuelta al Cole, el primero del curso académico, en el que se va a hablar sobre TBS. Y yo he querido hacer una pequeña introducción para recalcar el papel que tiene el TBS en la valoración del riesgo de fractura osteoporótica. Para eso lo primero es dimensionar la osteoporosis en sí. A mí me gusta siempre que hablo de osteoporosis comenzar con una diapositiva de este estilo, porque en Europa hay 2 fracturas cada minuto por osteoporosis y en España, aunque los datos que tenemos son bastante antiguos, ya nos hablaban de 3 millones de pacientes osteoporóticos, de los cuales 2 millones y pico son osteoporóticas, mujeres. Nos hablaban de más de 250.000 fracturas y de esta manera más o menos 1 de cada 4 mujeres a partir de los 50 años sufrirá osteoporosis y el riesgo vitalicio de fractura a partir de esa edad es casi de 40%. Yo creo que esas cifras ya son aplastantes, pero hay una más que me gustaría compartiros y es que gran parte de las mujeres posmenopáusicas al único médico que visitan anualmente es a nosotros, a los ginecólogos, con lo cual nos toca desempeñar un papel en este sentido. Y de hecho, si la entidad se llama osteoporosis posmenopáusica, evidentemente algo tiene que ver con la menopausia y algo nos toca a los ginecólogos. Así las cosas, antiguamente hablamos de osteoporosis como una enfermedad caracterizada por una baja masa ósea, es decir, era simplemente una cuestión de cantidad de hueso aquella en la que nos fijábamos. Pero hacía más de 20 años que esta definición se retocó y esta redefinición de la osteoporosis nos habla ya de un trastorno del esqueleto, no de una patología, no de una enfermedad, sino que es un factor de riesgo para la fractura y que se caracteriza por una alteración de la resistencia del hueso. De manera que esto tiene que ver con la densidad ósea, pero también con la calidad del hueso. Y la densidad ósea, pues se medica muy bien, tenemos diferentes instrumentos para poderlo hacer, técnicas, centrales, periféricas, pero la calidad del hueso era la asignatura pendiente en la práctica clínica diaria, porque si bien es verdad que en ensayos clínicos bueno, se puede medir mediante biopsias, etcétera, pues en la práctica habitual pues no estaba disponible ninguna técnica. Bueno, pues de eso es de lo que se va a hablar hoy, de una de esas técnicas para valorar la calidad del hueso, el Trabecular Bone Score, el TBS, del que, bueno, pues ya no voy a hablar más porque lo van a hacer los ponentes a continuación, pero que básicamente pues lo que nos permite es valorar por un programa informático esa microarquitectura del hueso que se va a correlacionar también con el riesgo de fractura. Y nada más por mi parte en esta introducción, os dejo con los ponentes y espero que el webinar os sea de muchísima utilidad. Muy buenas tardes a todos.
Bueno, muchas gracias a la doctora Silvia por su participación y como había dicho, esta fuera una pequeña introducción al dominio de la osteoporosis, pero después sería nuestra parte de presentar un poquito más lo que es el TBC y cómo el TBC puede ayudar vosotros doctores al estudio de los huesos, especialmente de las mujeres con menopausia. Entonces, doctora Karen, please, you can start the presentation.
Thank you very much. Here we go. Okay, Anthony, you can confirm you can see the slides?
We see the presentation slides, not the good one.
Okay. Thank you. Same again.
Exactly, yes.
Okay. How is that?
Now it's okay. It's okay.
Now it's
Yeah,
okay.
that's it.
Perfect. Okay. So thank you everyone for joining this webinar this evening. And as you probably have guessed, I'm here to talk about trabecular bone score. And the evidence I'll be presenting today is based on what we know now in 2025. So that includes an update, including the international clinical guidelines from the Osteo and IOF. So I'm Karen Hines. It's a pleasure to be here. And we hopefully will have time for questions at the end as well. So welcome, and here is the overview of my presentation. So I will start with a prologue, a small introduction to the challenge that we see in clinical practice on a daily basis. I will then introduce you to TBS, which is our solution to that challenge. And as I do that, I'll present the evidence that gives us confidence in the use of TBS to improve patient care. I'll then touch upon the international position statements, and then we'll talk about how actually you can make this work into your average daily clinical routine alongside your BMD assessment. So here we have it. There are millions of fractures occur every year, as Dr. Sylvia has already talked to you about just in the previous presentation. These fractures bring hidden costs. The risks are rising over time. We know that there's actually now a fracture epidemic. And with that, these fractures are bringing pain for patients, but also an increased risk of mortality. But what we should remember is that fractures, while they do happen in older people, there should not be a normal consequence of getting older. We can do better in terms of preventing these fractures. And to do that, we need to be better at case finding. So in terms of the statistics, I'd actually like to update on Dr. Sylvia in terms of the recent IOF statistics presented. And in fact, one fracture is occurring every second worldwide. So we can see there that there's been an increase, and there is still a major global concern about osteoporosis and the rising costs and prevalence. 1 in 2 women and 1 in 5 men will be affected. Even still, these numbers continue to rise. So by 2050, we will see an increase in around 300 to 400% in the rate of hip fractures. So that's a huge increase, and this will continue if we don't improve our case finding. The cost of that is significant. We're looking at $124 billion per year. It is huge. Yes, I've mentioned the mortality risk as well with fractures, and hip fractures in particular bring a 20 to 40% increased risk of 1-year mortality in older adults. This, if it doesn't kill you, it's going to bring significant impact on quality of life. And this can include an increase in reliance on social care, but also there will be pain and there will be a loss of mobility, all which is not good for people who are living longer and want to live healthier. However, here is the interesting statistic, which this has been happening for 20 years as such, and we'll talk about that very soon. But if more than 50% of major fractures are actually occurring in patients who do not have osteoporosis by BMD alone. We'll come back to that. We also know that there's a treatment gap. We know 70 to 80% of individuals who are going to fracture are actually undiagnosed. So this is why we need to be better at case finding. We can go one step further and look at, okay, well, these patients perhaps might fracture, or these patients might be going in for surgery because of fracture or for any other reason. But we also know that when it comes to surgery, 30% of implant failures are due to a loosening or a periprosthetic fracture because of bone fragility. So there's wider implications of bone fragility beyond the osteoporotic fracture that we must not lose sight of. So this is, I'd like you to work along with me with this case and consider perhaps who of these 2 patients are more likely to fracture. So here we have 2 women. They are both age 70. And if we look at their bone density from their lumbar spine DEXA scan, we can see that they both have the same bone density, and that bone density is in the osteopenic zone. So this could create a question, okay, well, out of these 2 women, do I know who is more likely to fracture based on their DEXA scan? You don't, but you can see that the lady on the right has a much poorer bone microarchitecture. So whereas they have the same bone density, deep within the bone, the scaffolding of the bone is very different. And because of this, the lady on the right, and we know this from the evidence, she is more likely to fracture than the lady on the left, and actually really needs to be on an osteoporosis treatment. And a nice analogy we can use is, you can imagine the Eiffel Tower. So with your neighbors in France, and you can have a nice strong structure there with the Eiffel Tower. There's a lot of metal, there's a lot of mass. But actually, if that Eiffel Tower was not arranged in the appropriate way to hold that load and to withstand force, then it would fail. So the Eiffel Tower is a successful building structure because of the way the trusses of the metal are arranged, which creates a solid structure. Now in bone, it is the same. We need a solid structure. If that's not solid, if there are gaps, there's going to be a failure of that bone. And there you have it. And this is why we need to look at both the bone density and the bone microarchitecture. Now, one more slide before we get into that. So let's look at bone density. We use bone density with our DEXA on a daily basis. This is our gold standard method for osteoporosis assessment, and it has been for 3 decades now. And we all know osteoporosis is diagnosed as the bone density T-score of -2.5 or less. If we are then to go into the science, and if we look at the population cohort studies, and I have a few of these listed in the table on your left, you can see the cohorts and you can see the proportion of women and men who fractured corresponding to their BMD. So we can see that for osteoporosis, the proportion of patients who fractured was between 21 and 44%. So we're not capturing everyone by looking at just bone density alone. Now, if you look in the blue shaded areas, those proportions of patients are patients who actually fractured. So we can see that more patients are actually fracturing because of osteoporosis in the normal and osteopenia categories, which is quite ironic. We know BMD works, but it doesn't work for everybody. It works for a certain selection of patients. And we can see this from years of evidence. So bone density alone is not enough. And if we look on the right-hand side of the screen, this is a seminal study by Series and colleagues from 2004. It's a very early study. And this really, the team were looking to see how many fractures were taking place in osteoporotic women. And when conducting the study, they were very surprised to see that actually most of the fractures and most women who were fracturing were in the osteopenic zone. And you can see this on the chart. And this came as a surprise. And from that point onwards, there was more of an interest in terms of, okay, well, bone density isn't picking up everybody. We need to be better at case finding. And then we saw the introduction of FRAX, and then we saw the introduction of TBS, which I'm going to present to you. So here we are looking behind BMD within the same DEXA scan. This is our solution. So trabecular bone score is a validated surrogate of bone microarchitecture, and it has been validated since 2008. In the chart on your right, you will see the results of one of those validation studies, which shows the relationship between TBS with important three-dimensional criterion micro-CT trabecular bone microarchitecture parameters. And those correlations are very strong, relating to trabecular separation and trabecular connectivity, etc. And that was one of the first studies to show that the validation for TBS. And since that time, there have been subsequent studies to confirm that, which then has underpinned our approvals in Europe and in the US. So we have actually been in clinical practice since 2012, so well over 1 decade. And in the US, this TBS is now reimbursed, and it has been since 2022. So we have that market acceptance and that trust, importantly, with our doctors who we work with. You can see how the TBS works on the left, and here you have the grayscale bone mineral density image, which you will all be familiar with from your DEXA machine. And then on the right, you see what we call a heat map. And that's a heat map which indicates that a trabecular bone score examination has taken place at the same time as the BMD. And this is basically the application of the experimental variogram, which assesses the bone texture and the position and the distribution of those grayscale pixels, which correlate strongly with bone microarchitecture by micro-CT. With TBS, we have our 3 categories as well. You can have a patient who has normal TBS, so normal bone microarchitecture, partially degraded or degraded, which is quite very bad bone microarchitecture, very poor. So here we have a similar situation as we looked at earlier. So we have 2 patients, they have the same bone density. The patients then received a trabecular bone score, and then at that point, the patient with the poorest bone microarchitecture was detected, and that patient had the higher fracture risk. Now, if this patient we then transfer to the bone fragility index, this bone fragility index you'll see with the colorful matrix, this is included in the TBS report, and it's actually very useful because what it enables you to do is to visualize the patient's bone density alongside the patient's TBS category. And if you have a patient who is in the osteopenic zone, they will fall into either zone 4, 5, or 6. Around 30% of those patients will have degraded or partially degraded TBS. And you can see actually in zone 6, those patients with a degraded TBS have a similar risk of fracture to a patient who has osteoporosis by bone density. So we're refining that fracture risk. We can also look at those patients who might have completely normal bone density. And these present a real challenge in clinical practice. So their T-scores will be -1 or better. And actually in these patients, they still fracture. So they're still sustaining a bone fragility fracture. Now, these two studies were conducted to find out what differentiates these patients. If their bone density is normal, why are they still having a fragility fracture that you would call an osteoporotic fracture? In the first study, this was a registry-based cohort study, so the very large population cohort from Manitoba in Canada. 50% of those women who had normal bone density were actually found to have a degraded TBS. So had the TBS been used in these women, it could have refined the fracture risk and identified these women who were then going to have that high risk of fracture despite having a normal bone density. In the study on your right, this was a study of an FLS, so the fracture liaison service. And in the patients who fractured, but who had normal bone density, around half of those patients had low Hounsfield units, which is a measure on CT to assess a patient's bone mass. And it's accepted more of a criterion method with benefits beyond DEXA. But then also in these patients, 42% had low TBS. So you can see how BMD by DEXA is not always useful by itself, but when you bring in the other tools to look at fracture risk, you can refine that risk and you have a greater, more holistic picture of a patient's bone health. Now, this is actually particularly useful in patients who may have risks for secondary osteoporosis. So these are patients on this slide there was a study conducted in patients who are on glucocorticoids. And we all know that glucocorticoids bring a risk of osteoporosis because of the nature of that drug, which can increase the fracture risk by up to 6-fold. But actually, by using BMD alone, it's not always effective in identifying these patients who then go on to fracture. So this is a bit of a problem in clinical practice. This study, I had patients with glucocorticoid-induced osteoporosis, they had fracture, and BMD was able to identify around 30 to 38% of patients who had a vertebral fracture or any major osteoporotic fracture. When TBS was investigated in the study, TBS was able to identify 76% of those cases for vertebral fracture and 69% of those cases for major osteoporotic fracture. So this is a huge benefit, and actually when you put the two together, it's even better. A similar situation for patients with inflammatory disease, where bone density can appear normal despite an underlying bone fragility. In this study by Kang and colleagues in 2018, it studied patients with axial spondyloarthritis. And these patients who had fractures were, again, just like the previous study, they were more likely to have a degraded TBS rather than a spine or hip BMD. So whereas BMD was useful for some patients, it wasn't identifying all of those patients who had a fracture. So putting it together, TBS was the strongest predictor in this study and was very useful for identifying patients who needed treatment. And linking into treatment, a recent study from Germany in 2023 looked at their whole clinical practice. And this was more of a real-life study, and they found that 40% of their patients who had secondary osteoporosis were actually, when they received their TBS, this influenced the treatment decisions from the doctors. So the addition of TBS was found to be useful in 40% of those patients to add something beyond the bone density. Okay, so one more slide on reclassification. This is looking at patients as a whole. So we're looking at postmenopausal osteoporosis, osteoporosis in men, osteoporosis in secondary osteoporosis as well. And this is just one example. I've used this one because it's Manitoba. It's a huge study, but there are others. And what we're seeing from the evidence over 10 years is that TBS reclassifies those patients at highest risk who may need treatment. And these are patients who might fall in the osteopenic zone, as you can see, but also TBS is useful for redefining very high risk. in patients who have osteoporosis, but also have degraded TBS. And these are the patients who you need to get on an osteoanabolic, and we'll come to that soon. In terms of the evidence, I won't go through each and every one of these studies. These are population cohort studies and studies which were included in the FRAX meta-analysis, which underpins the use of TBS in clinical practice alongside BMD and alongside FRAX. This evidence was reviewed as part of the systematic reviews for the recent guidelines. So in practice, we do have a report with TBS Osteo whereby the FRAX can be adjusted for TBS and the BMD T-score can be adjusted for TBS. The evidence for the FRAX adjustment was published by Eugene McCloskey in 2016, based on a meta-analysis and validation in 14 independent cohorts from around the world. And what they found is that addition of TBS together with BMD and together with the FRAX clinical risk factors was able to improve the prediction of patients who then were fracturing. So that risk of major osteoporotic fracture, those gradients of risk increased when TBS was added. And similarly with the BMD T-score adjusted for TBS, this was validated by Bill Leslie and colleagues in 2018, again using the Manitoba cohort for this study. And what they found was that when TBS was added to the BMD T-score, there was a refinement of fracture risk. Those patients who fractured but had osteopenia were better identified. And actually, this could be done by adjusting the BMD T-score for TBS. And that adjustment could take place using the femoral neck BMD T-score or the lumbar spine BMD T-score as well. And that is now embedded into our software. So now we have our bone assessment in patients. We now need to think about, well, how might TBS be able to inform treatment decision-making? I like this slide because it's good to talk about having the right treatment for the right patient and also at the right time. And when we do that, we consider the impact of those treatments on bone density and also on bone microarchitecture, because we're looking at both now. We've got your bone density and we have your TBS. And when we do that, we also consider the treatment mechanisms of action. And with those anabolic treatments, they stimulate osteoblasts. And because they stimulate the bone formation, what they do is improve the trabecular connectivity, they improve the trabecular thickness, and because of that, they improve the overall bone quality. So it's very much anabolic, and it's having an effect on not just the mass, but also the structure of the bone. And because of that, we see improvements in TBS, which I will come on to in the next slides. Denosumab is in the middle. So denosumab is, it has a remodeling transient effect, but also an anabolic action. Denosumab will inhibit, so it will reduce the osteoclast activity. And because of that, it can preserve the existing bone microarchitecture. And there is also a resorption suppression. So there's a suppression of bone resorption, which then gives more time for the bone formation process. So with denosumab, we would expect to see some preservation, but also some improvements in bone microarchitecture and TBS alongside BMD. Now, with the bisphosphonates, they are very much remodeling transients. So they're very much the anti-resorptive medicines. And because of that, we're not expecting to see any formation, any building of that scaffolding within the bone. We expect to see no change with these treatments. And I'm happy to introduce some of the studies that have been published over the last 5 years. So here is a study which was a 10-year investigation of denosumab by Didier Hans and colleagues. And what you can see very clearly from this chart is that over the course of this study, patients who received a denosumab treatment experienced an increase in their TBS over time that was sustained up to 4 years, up to 6 years, and up to 10 years. And you can see that gradual sustained improvement in their TBS. And those patients who were on the placebo you can see there was no response, and some patients actually lost their TBS. They had a reduction there. But then once those patients were switched on to the denosumab, you can see with that dark blue line that those patients' TBS improved again over time, and there was a catch-up. Let's look now at the osteoanabolic treatment. So with abaloparatide, this was an earlier study in 2018. And this study randomized patients to either the placebo or which was teriparatide and abaloparatide at 3 different dosing regimes. Now, we can see the abaloparatide dosing regime at 80 micrograms was much more successful at improving TBS over the course of the 24-week treatment. So there seems to be a dose response there. So with that 80 treatment dose, and the placebo showed a non-significant decrease over time. Looking at abaloparatide treatments even further with Felicity Kosman's study in 2023, this study randomized women to the abaloparatide at the higher dose or the placebo for 18 months, followed by a course of alendronate. Now, again, what you're seeing here in the green line, you can see that those patients who were randomized to the higher dose of abaloparatide had an increase in their TBS over time, and that was sustained with a follow-on sequential treatment with alendronate. Those patients who were on the placebo and then they were moved onto the alendronate, you can see an increase there, but not as high as the increase as you saw with the abaloparatide treatment. And we also see actually on the right graph that patients, by the end of the trial, there were less patients who had degraded TBS. So we saw a change in category there, which is exactly what you want to aim for. So here we have romosozumab, which you'll all be very much aware of as a very potent anabolic osteoporosis treatment. And here is a study by Mike McClung and colleagues in 2022. And they had a 12-month romosozumab followed by a 24-month alendronate trial. In the orange, you can see those patients who were on the romosozumab. On your left, you have the BMD changes. On the right, you have TBS changes. They follow the same pattern. So there's a sharp improvement in BMD and TBS with romosozumab over 12 months, which is then sustained with the 24 months of alendronate over time. Those patients who were only on the alendronate from the beginning, you can see those increases are certainly not as high as those patients on the Romo. And of course, this reflects the mechanism of action of that treatment. The improvements in patients' TBS was actually independently also associated with a reduction in vertebral fractures during the study period, which was very interesting to note. Now, I found this one quite interesting. This is a very recent study which was presented at the World Congress this year by Dr. Chadi Raki and colleagues from the Robert Jones and Angus Hunt Orthopaedic Hospital of the NHS in the UK. And this is real world evidence. So these patients were put on romosozumab. And in fact, there was a DEXA scan which was conducted at 6 months, so 6 months post-treatment. And in just those 6 months, there was a significant improvement in BMD and TBS. But actually, the clinically meaningful changes, which I have highlighted here in yellow, which means it was a change that exceeded LSC, was very significant for those in TBS. So 38% of patients had a clinically meaningful improvement in TBS in just 6 months with romosozumab. And this was made me very happy, of course, because these statistics are excellent and shows the response of the bone microarchitecture and the BMD to this treatment. And it's very, very good news for patients. So we're looking forward to seeing the follow-up of this study at 12 months and then sequential treatment from that time onwards. A similar situation with romosozumab in type 2 diabetes. We see the same magnitudes of increase in TBS over time with romosozumab in patients with the type 2 diabetes, who, as you know, are quite a challenging patient population to manage. But yes, very responsive to romosozumab. When we monitor changes with bone density on DEXA, you will be considering the precision of your BMD measurements and the least significant change to know what's a clinically meaningful change. Now, just in the same way as you apply that for bone density, you also apply that for TBS. And on this table, you will see the list of studies which have been published over time using different DEXA systems, different TBS versions. And these studies have published their own in their own individual center precision values and their least significant change values. And when we put these all together, the average is 1.37% coefficient of variation for precision, which is then corresponding to a 3.79% least significant change. So really, if your patient is, over the course of 12 months, you're seeing a positive improvement which exceeds 3.79, then you know that your patient has had a clinically meaningful improvement in their bone microarchitecture. We can put this all together, and on the left you can see the nice colorful chart with the balloons on there, and in terms of that really shows you how patients are responding to different treatments in terms of their bone density and in terms of their TBS. And just like we witnessed in the description of the study results, we can see those anabolic treatments are having a stronger effect on both the TBS and BMD, as expected, in accordance with the mechanisms of action. Okay, so how are we doing around the world, and what's our clinical acceptance? Well, we have well over 4 million TBS assessments are being conducted worldwide every year. I think we're probably hitting on 6 million at the moment. Where in over 90 countries, there are over 1,500 peer-reviewed publications which underpin the applicability of TBS in practice and the clinical performance. Because of that, we are now proudly in over 35 guidelines around the world, including the international guidelines, and in the US, we have our reimbursements. So we're really glad to say that TBS is reaching patients, which is exactly what we want. And this has been helped by international position statements. Here we have a major statement from the SKO and IOF, which is under the auspices of the World Health Organization and published in 2023. This paper is available, it's open access. You don't have to pay for it, and you can find it using the Osteoporosis International website. Now, I can also send a link of that in the chat or post our presentation, post-webinar, if you're interested. But these guidelines were based on 96 studies that would fit the criteria of acceptance for the systematic reviews. There were 3 systematic reviews as part of this exercise, which covered primary osteoporosis, secondary osteoporosis, and treatment decision-making and monitoring. And from that systematic review and the expert panel review, there were 22 statements that were published to guide the use of TBS in practice. And those statements were rated by the working group as being as strong according to the grade criteria. So that's in a nutshell, if we're to summarize that, for primary osteoporosis, TBS was confirmed to predict fractures independent of bone density and clinical risk factors, which is very important to have that independence. So you're having an added value in your fracture risk assessment. For secondary osteoporosis, it was concluded by the working group that TBS predicts fracture risk in secondary osteoporosis, and actually also that TBS is degraded and is affected in most conditions of secondary osteoporosis because of that impact on the bone quality. And also, and I haven't presented it today, but the TBS responds quite negatively to aromatase inhibitor treatment as well for patients who you are treating for breast cancer. So want to be aware of to monitor your patients under breast cancer treatment for their TBS as well as their BMD. It's very important. In terms of treatment, we had a working group expert statements which confirmed that TBS is helpful for stratifying osteoporosis treatment and for monitoring response, especially to those anabolic treatments in both primary and secondary osteoporosis. So actually, you've just noticed you have a QR code there as well, which should take you to that paper. So how do we make it happen? How do we fit TBS into the daily workflow? So here we have a schematic which explains exactly how, and I will keep it very simple if you have an adult patient who is aged 20 years and over, who you are referring for a BMD DEXA scan, that patient should also have a TBS scan at the same time. So we have the same criteria for TBS that you have for bone density. So that's the easy part. I will put a caveat in there in that next year we are releasing a pediatric version of TBS, which means then that the TBS can be assessed in patients from age 5 to 20. But here we're focusing on the adults. So you will check the criteria, you will check the image quality. In terms of image quality, you will be aware that osteoarthritis can impact the spine and bone density scan by artificially elevating BMD. And this can be a challenge. And the question is often asked to us, well, is TBS affected by degenerative changes? And in fact, this was the first study which showed absolutely not. So TBS is not impacted by degenerative changes, so by osteoarthritis at the spine. So you're fine to do your TBS assessment in these patients. And actually, since this study by Hayden and colleagues in 2022, there have been, I would say, I think there's 5 more studies since this time which have confirmed that, and confirmed even sometimes with those moderate spinal degenerative changes, there's no effect on the TBS. So you can have some confidence there. And this was all validated with CT as the gold criterion. So we have confidence in the quality of the assessments. Then you've got your scan, and then you need to make the decision, well, how is the bone density of my patient? Is there a vertebral fracture? And how is the bone microarchitecture? So you can see already you have more of a holistic picture there. Then you ask, how is the patient's overall bone status? On your report, these are the key outcomes you will see. We have the bone fragility matrix, which is, again, what we saw very early on in this webinar, which is the colorful 9-zone matrix, where you can visualize where your patient fits in terms of their BMD score and their TBS category. Then you also have an option of having a FRAX adjusted for TBS. This is in the software for TBS Osteo. You will have this automatically in there. And you may find your patient, their risk can be adjusted, as you can see on here. That can mean that sometimes those patients are then eligible for treatment, having not been eligible before, once the TBS is included. The same with the BMD score. The BMD score has an adjustment for TBS. So this enables the BMD and the bone microarchitecture to be considered in the same analysis. And again, that can mean that sometimes patients who weren't eligible for treatment just based on their BMD score, they're now eligible for treatment once you add that TBS. And then you might ask, okay, I've found my patients. Now, should I treat? How should I treat? And how long should I treat? Now, the adjustment of the T-scores and the FRAX adjustment can indicate if you need to treat these patients. And then in terms of the treatment classification, knowing what we know about treatment mechanisms of action, this may be able to inform your treatment decision-making in terms of what treatment is best suited for your patient. You can see the light bulb on this slide, and this is because this is more conceptual at the moment. We don't have this in guidelines. There is an ongoing meta-analysis which demonstrates the value of using this approach to make treatment decisions. But here is kind of what you'd expect. For patients who do have degraded microarchitecture, the anabolic treatments or the denosumab is going to have the most efficacious treatment effect compared to those bisphosphonates. So you have more information to help make your decisions on what patient should have what treatment. Okay. And in terms of treatment duration, we need to be thinking about, well, how do we reduce the fracture risk? And it's from moving patients from the high risk zone to a lower risk zone. And you can see those patients who you need to move from a high to a lower zone according to a straight horizontal arrow, which you can see in the matrix, that indicates a treatment choice that will influence bone density only. But those patients who have an oblique arrow. So you want them to move them from the high zone to the lower zone according to the oblique movement across the matrix. You're going to need a treatment that impacts not only the bone density, but also the bone microarchitecture. And that brings me to the end of my presentation. So I hope you found that useful, and perhaps we'll have time for some questions. But as you can see on the picture here, even if you do not see it, sometimes the structure really matters. Thank you.
Muchas gracias, doctora Karen. Entonces, ahora tenemos algunos minutos para tener las preguntas. Entonces, si vosotros tenéis preguntas, no dudes en hacerlas en la parte de preguntas y después yo me encargaré de hacer la translación para que la doctora Karen pueda contestar a todas las preguntas. Entonces, yo tengo una pequeña pregunta. Es que quería saber si I have a little question. It's if we only use the BMD to detect patients, how many patients without, how many patients are we going to, with the risk of osteoporosis, are we going to meet without the TBS?
Without the TPS specifically, we know from the research it can be in some studies up to 40%. We know on average we've seen, depending on the guidelines, 25%, with the Manitoba, 30%. It depends on the guidelines and the thresholds that you use, but it can be quite significant. Of course, we're not going to be able to identify all patients, so those 70% who are missed, but we're certainly making a big difference into closing that treatment gap when TBS is added.
Okay. Another question is, when a patient has like an artifact in his vertebra, how can it affect the TBS score?
The artifact would need to be excluded because the artifact, so we have a couple of factors that can impact TBS assessment. We have laminectomy, and we have if there's a metal artifact in that vertebra. So if you don't have two evaluable vertebrae, then the TBS assessment will not be possible in the same way as BMD would not be possible. But if you're looking at artifacts that are due to degenerative changes, we don't have any impact on that. So we have some confidence in that one.
Great. Entonces, veo, vosotros no dudéis en hacer las preguntas. For the moment, we don't have a lot of questions. I think because also it's really late and I think everybody wants to enjoy the night and also to relax. Creo, ¿cómo modifica el ejercicio la TBS? Just a question from an Alfonso. How does TBS will modify the clinical routine every day?
Yeah, it's not going to change your routine, actually. It's because the assessment of TBS is seamlessly part of your routine at the same time as the BMD. But what it will do is you'll have a more comprehensive report, which means you are able to really have an overall picture of your patient's bone health. So not just bone density, but you have confidence because you also have an additional measure, which is the TBS, which gives an indication of bone microarchitecture. So where it's not going to take you any more time in your clinical workflow, it's going to give you that added value for your patient to better refine their risk. And actually, you'll find that patients who might not have been on a treatment, you can then move them onto a treatment because they have a degraded microarchitecture.
Sí, lo que quiero también agregar es que como el TBS es un software que se pone directamente en la densitometría, o sea, el TBS trabaja en paralelo del software de la DEXA y entonces al final vosotros tenéis la valor de la DMO y también del DBS al mismo tiempo y como el TBS está en la densitometría ósea, no toma más tiempo para tener los valores de la DMO y también del TBS. Tenemos una pregunta, can we get this calculator? Entonces, Karen.
So the calculator for the TBS or for the FRAX?
Alors, I think it's for the TBS.
Uh-huh.
To get the TBS score, the TBS, it's a
Oh,
software enfin, el TBS es un software que puede poner en la máquina de densitometría ósea. Cuando se pone el TBS en esta máquina, entonces el software va a usar las imágenes de la densitometría ósea para calcular el score del TBS y al final brindar a vosotros el score de la DMO y también del TBS al mismo tiempo. Pero al inicio será un software a instalar en la máquina de densitometría ósea. Y después también yo quiero agregar que enfin, en los informes de TBS se puede, tendrá los valores de la DMO, también del TBS y también del FRAX. Todas las informaciones están presentes en el mismo informe. Bueno, perfecto. Espero que estábamos claro. I hope that we were clear. Do we have other questions? For the moment, no. Alors, si. Después, it's not a question. Okay. It's not a question. Fantastic presentation. Congratulations, Dr. Hind. Thank you so much for introducing us to TBS and its application in healthcare practice to improve the quality of life of menopausal women. Thank you very much. Muchas gracias. Muchas gracias.
thank you.
Bueno, entonces, bueno, a todos, muchas gracias para estar esta noche con nosotros y por la presentación. Si no tenéis además preguntas, creo que podemos terminar este webinar. Quiero agregar otra vez, de nuevo, muchas gracias a la Asociación Española del Estudio de la Menopausia para permitirnos de hacer este webinar, de presentar, de tener la oportunidad de presentaros el TBS. También, si tenéis preguntas, no dudéis a contactarnos, a contactarme Medimás directamente. Creo que, no sé, yo podré poner en el chat mi correo electrónico para que después puedan contactar, para que después, si tenéis preguntas, pueden contactarme y que yo pueda contestaros directamente sin problema. Después, yo también enviaré diferentes correos electrónicos para que puedan tener también la grabación de esta reunión para que puedan verla después si necesitáis ver las informaciones otra vez. Entonces, muchísimas gracias. Este ponente es magnífica. Perfecto. Muchas gracias, José. Muchas gracias. Okay, thank you, Karen, for this presentation again.
Welcome.
Muchas gracias a vosotros. Se puede ver mi correo electrónico que está presente aquí. No dudéis, os deseo una buena noche. Muchas gracias a todos. Thank you very much, Dr.
Thank you.
Karen.
Bye-bye.
Bye.
Thank you.